pharmacist by background. I admittedly am a complete imposter when it comes to paediatric cancer and blood or paediatric care. I'm the clinical lead for the Roro project, which is a electronic prescribing and administration system that's being built for the northern region over the past 4 years. So I've got here with me today, we've got Radhika, who I'm sure many of you know, pediatric pharmacist from Starship, and we've also got Amanda here as well. And we've got Stephen and Mark joining us here too. Now, we've got quite a few people on the call. In the interest of time, we probably won't do a full round of introductions, but I would just like to get a sense of, I don't know if you can do this, Amanda, or not, just to make sure we've got all our districts covered. So I'm not sure if you can just snoop on the people on the call and just note down if we've got at least one person from each of the districts, so we can just tidy up after tomorrow's session if we've missed anyone. Okay, cool. Cheers for that. All right, so I do have a few slides to go through, as well as a sort of a sample of the new prescription that we'll be sending down as part of shared care, and then after that we'll have some questions. So I'll just share my screen. Okay, so as mentioned, we'll just do a little bit of background on the system, and let me swap the monitor. And then we'll just talk about what's changing and what's not changing when it comes to the use of the new chemotherapy prescription, implications for shared care sites, and then we'll have a look at the new chart or PDF, and there'll be ability to raise any questions or concerns. So the northern region has been trying to digitize chemotherapy prescribing for a number of times. There's been sort of 3 previous attempts. During COVID in 2020, that the organization decided to adopt kind of a build your own system approach rather than looking at something off the shelf. One of the main drivers for that really was that, Mosaic and other systems couldn't handle some of the complexities of pediatric therapy. So that was one of the main reasons we wanted to build our own system, so that we could make sure that the system would be able to deliver both adult and pediatric oncology and hematology care. So we're kind of at the tail end of that journey now. We've implemented the system across the northern region in hematology and oncology sites and the adult services for Northland, Auckland City Hospital Hematology and Oncology, Waitemata and Counties Hematology. And pediatrics is the lucky last service to go live. Just by a small amount of background, that the system has end-to-end workflow. It has a formulary and protocol builder, a prescribing component, a pharmacy, clinical screening and supply module, as well as the administration module. So it's an electronic and prescribing administration system, and not just a prescribing system. I won't go through these in any detail, but just for anyone that's curious, this is a kind of a screenshot of our medication chart that the nurses administer chemo off. There's also an iPad device. This is a picture of the prescribers page where you can see, the diagnoses on one side and their view of the chart on the other. I won't go through these. It's just really to show you, just out of interest, that you can get a sense of just kind of what it looks like. In terms of our plan, we are 3 weeks out from our intended go live date on the 7th of October. So inpatient and outpatient treatments, anyone who's being looked under the care of Starship Cancer and Blood for malignancy will be going live at the same time. So this includes transplant, inpatient and outpatient therapy. So we are splitting our implementation into 2 little brackets. Our prescribers will start putting patients onto the system on the week of the 7th, and any patients that are having chemotherapy administered from the 14th of October will be starting up here from the 14th. Now, any current shared care patient or paper prescription that's in progress will be staying on paper, but potentially any new charts from the Roro system may begin to be seen, from the 14th, as that's when administration starts. Probably you'll be a little bit later than that, I imagine, but potentially it could start from the 14th of October. In terms of the changes that are coming, all of the chemotherapy doses for patients under the care of Starship Cancer Blood will be prescribed within the Roronahe system. For patients in the northern region, so it's including Northland, doses given on site, so parental doses given on site will be administered within the system. Obviously, anything that's being given taken by the patient at home, we won't necessarily be recording those, but all of those ones where someone from the northern region is administering the medicine, be it community or in the hospital, those will be administered from the system. And then shared care patients outside of the northern region, so south of Auckland, will be documented still on paper from a chart PDF that will be generated from the system. So that's the initial plan. What I will say is that this is a cloud-based, website application. So theoretically, anyone with a login can log in from anywhere in the country and potentially use the system. So we think from a long-term perspective, it would be ideal for other sites that we share, care with patients to be able to use the system to either order a chemo dose and administer a chemo dose. But as you can imagine, the change management and sort of the training and also the preparedness for all that kind of thing would be a separate project. There's certainly interest from other districts around using Roronahe more broadly as a prescribing system or an alternative to Mosaic. There's interest from Te Manawataki, as well as some Waitaha in South Canterbury. But I think, as we all know, that the current climate at the moment within our organisations is not very friendly to new projects and things. So there's certainly maybe I did want to sort of just mention that we would prefer to not have to shuffle bits of paper around. But in the interim, in the medium term, we'll be using this system of sending the paper documentation, and we'll have a look at those as part of this session. So what I wanted to make sure that was also clear is that we're not really looking to change the overall process at all or expectations around what's being administered. So any referrals and associated documentation, with the exception of the chart, will remain unchanged. It's really just the prescription that we'll be sending that's going to look different and be a little bit different. Everything else will be as is the current practice. So our system will produce a PDF from the electronic prescription, which will be attached and sent with the referral. Now, unfortunately, I'm not sure if you're familiar with sort of electronic printouts from systems, but we can't get our chart to be as tidy as sort of 3 pieces of paper like you're kind of used to on the currently, nicely formatted paper prescriptions. We have done quite a bit of work to get the prescription size down, which you can see today. But we are sort of looking in the order of somewhere between 6 to 10 or 11 pages potentially. Printed double side, hopefully that's not too bad. But yeah, it's not going to be quite as tidily formatted as you're used to, which we'll have a look at. Pharmacy will need to order any required doses from this new chemotherapy chart as per the usual process, and we'll need the PDF to be printed off in full, the associated doses signed for just as usual, and then for that to be completed and scanned back in full to the service as usual. So the bottom line is everything's staying the same, except the chart's going to be a bit different. All right, so I'll just jump out of there now, and we'll just have a look at the PDF preview that we've created. Okay, so you can see this one is it's a consolidation for ALL, and it's just from a test patient. But hopefully, let me know if it's too small. I'll just zoom in a little bit. But we basically have a header. There will be the address of the ordering site up here at the top. That just still needs to be added. There's a few little tweaks that we're still doing on this, and it's kind of continuously a work in progress. So we have our patient details here, the protocol that the patient is on, the height, weight, and body surface area, and the address of the patient. Our system does have an electronic consent feature as well, so that will just also be mentioned if the patient's had consent. The diagnosis is listed. Our high-level diagnosis is listed here. So if the patient has allergies, those are on the front page. As part of the system, there is also some blood and investigation requirements that typically will get signed off from a safety perspective. So that's all just recorded here on the chart as well. So those will be filled out, obviously, within Starship. But just so you know that those things are on the chart too. I'm just actually going to scroll down to the main part of the chart. So you can see here we've got a PRN and stat section, which can be used to record PRN medicines. In practice, we're only looking for the chemotherapy doses to be administered. These kind of PRN antiemetics we'd expect to be charted from your usual prescriptions or usual chart and transcribed over. Okay, so I've gone through and actually administered some of these doses. I haven't done the full chart, but you can see for the day one here, we've got our cytarabine and some of the antiemetics administered. So stuff that's already been given will be printed off, come out as signed for, and you'll see the initials of when those were given. One thing to note is that to prevent the prescription from being overly long, any oral medications which go on for a duration of 14 days, they will appear on the first day they're on, and any doses will be here. But obviously, the plan is for any of those to be transcribed over. I'll just skip down to the day 8, which is what you guys will be mostly interested in. Okay. So here would be the day 8 methotrexate. So you'll have to forgive me. The intrathecal is on here. I didn't omit it from the chart, but the intrathecal would be crossed off. Have I opened the wrong chart? So sorry, guys.
Do you want to skip down to day 15?
Day 15. And then, sorry,
yeah.
yes, it's day 15, isn't it? Okay, yep, that's it. So here's the vincristine for day 15. So really, we've just essentially it's a chart, and there's a space here for administering. So we are adding some columns to make this a little bit tidier, but essentially you'll just record the date and time and the dose that was given and the initials of who gave and check by the chart. So that's really the gist of the chart. One thing I will mention is, rather than forcing our doctors to print these off and sign them and rescan them, we are going to be taking advantage of the Director General of Health's exemption, signature exemption to the medicines regulations. So we've just taken some steps to make sure that our chart's compliant for that. So it has to be generated from an electronic system. It will have to be emailed from a DHB address. We have the prescriber's name and NZMC number here, so they can only produce one of these by logging into the system with a username and password so that it's secure. And we've added the required text to say that the prescription meets the requirement of the Director General of Health authorization. So we know this was intended for kind of community pharmacy prescriptions, but we really feel like, because this is coming out of an electronic system and it's really a chart rather than a take-home prescription, that it's not necessary for the prescriber to sign every page. And so we've taken advantage of that exemption, which we understand will be rolling over for the next few years, to avoid needing to wet ink sign and rescan these prescriptions. Okay, so happy to look at anything in particular on this chart, but I'll pause there for questions and any queries or comments.
Just to add to what Dean said, these prescriptions will also include pre-medication. So historically, we've just given guidance that lives separate, or the pre-medication dose just says give loratadine, cetirizine, and the required famotidine as a required pre-medication, but doesn't necessarily specify the exact dose for the patient. In the example that Dean showed you, it will have that doses. So it might also help with that minimization of having to transcribe those supportive cares, or knowing what supportive cares that need to be given. So that will be there too.
Just wanted to encourage the nursing teams out there not to be shy. Now's your chance to ask questions. Seriously, I've had heaps of questions, so you guys have any, be great to see.
I've got one. What if a pre-medication, I'm trying to think of an example for, but I can't, but what if there was something that didn't require a pre-medication when the chart was done, but then does require one? Am I making sense? So they come back here
Yep.
and yeah.
So if you wanted, so if, for example, this is a bad example, but let's work with peg asparaginase as an example. We decide that they need hydrocortisone to be given with it as part of the additional pre-meds. If it happens at this point of prescribing, that will get added to the prescription by the prescribers up here. But if it's not on that prescription, your prescribers could do that on a separate sheet, just like you would currently now if we sent down a chemo script and you needed something extra.
Okay. Yeah.
I don't know whether you've had the opportunity, Amanda, to talk to the team about what your expectations are in terms of how they handle the, for example, 10 to 40 page PDFs that are generated. Are we wanting all pages to be sent back, or has that been discussed? Sorry if I'm asking a question that's been resolved.
So we've done some work on the chart, so that, yeah, for everyone on the call, they were kind of 40 plus pages previously, which was a bit untenable. So we've done a lot of work to trim them down with the developer, and now the longest ones are kind of about 10 to 12. So that's kind of the upper bound of the length of them now.
Okay, but we would expect that the complete, whatever that your total page number is, to come back. Would that be fair, Margaret and Amanda?
Yes, I think that's true. Yeah, I would like the complete PDF to come back to me. I think I appreciate it's tricky sometimes if you're doing day 8 of something and then day 15 and you've got a 10-page document that you're holding over a few weeks to send to us or not. I don't think it's unreasonable to send with an encounter that you've had that day, that singular chemo chart or that singular page that has a copy of your signatures of that chemo encounter for you that day, rather than sending the entire thing on week 1 and then again on week 2. Does that make sense?
That's right. Yeah.
Okay, so
Hi. So just from Palmerston North, just asking whether did you want the whole thing sent back at the end of it, or just the days? Because we will send it on the day that we give, scan it and send it to you, that single page. But then do you want the whole thing back at the end? Because that's all we're touching is those. It's a bit
What I'm anxious about is getting, having a multi-page document that I need to check through every page to make sure the right things have been charted. And so I think this is going to potentially evolve. And I'm happy in the moment, let's say on a weekly encounter, and if you're doing 4 days of cytarabine, you don't have to scan every day, just scan me the block. I guess if it's problematic, then we might need to change that, but I'm happy week by week to get the chemo pages that pertain to that week back only.
Okay, sounds good. Yeah, thank you.
And I guess the system's new to us as well. Some of the vagaries of the system and the things we're talking about as our solutions to them may not be what we end up with in 6 weeks' time, because there's something that's far more obvious. But so bear with us in terms of patience with if we do make other changes as things evolve. And don't hesitate to make suggestions for improvements if you're finding it unworkable at your end as well.
Roto team, could you explain what happens if we send a PDF of a chemo chart to a region and for some reason the date needs to change of the administration date?
I was just going to ask that.
What's the process for that?
I guess the question is, what is our current process for communicating date changes? Once you've already scanned the chart down to shared care, I'll pick Waikato as an example, sorry. But if you've scanned the chart to Waikato already, and then for whatever reason it can't be given on the Thursday and it needs to be given on the Wednesday, what is our current communication strategy for telling them that they could change the day? Do we rescan the chart with a new date change on it?
Sometimes that happens, yeah. Sometimes, am I wrong? Regions can tell me. Sometimes a regional clinician may redate at our directive.
Yeah.
That's what usually happens.
Yeah.
So,
and so on redating the Roto PDF, Radhika, how do we feel about that?
That would be a manual change. It wouldn't obviously, and then we would have to either reconcile that in our system in terms of moving the dates so that they match the treatment dates. So there's two ways of doing it. One is that there are two ways of doing this. One is you just manually change the date. I suspect this might be the easiest way, and then scan it to us. It might not be reflective of the dates in our system, and that's for us to deal with in terms of managing and documenting. Alternatively, we let us know that we need to change the dates, and then we can adjust the dates in the system and then send another PDF down with the new dates or the correct dates in there. Those are two options that are viable and feasible. It's just whichever one we want to pick. That's not to say that we can't change it if it's not working, but we just need to pick a method going forward. Do you have a preference in terms of how that might be?
Well, I don't know about Lisa, but certainly I think it's been on the site kind of at directive. It'll be really easy once it's all electronic around the motu, but if it's easy for us to change, but then it's a 10-page PDF generated, resent, and then that's creating a lot of drama.
And destroying the old one.
Yeah. So if the current practice has been for a lot of the people around the country to change it at the directive of the service here, I'm happy for that to continue and just reconcile it at this end, if you are okay with that. The regions and Amanda. Palmy's happy with it. Must be fine.
I'm sure that would be fine for us. Yeah.
I think we'll be fine with that too. Do that and tote on it. Yeah.
Amanda.
So, can I just ask a question about so currently we get the script and we ask our doctors to check it and sign it. Sorry, I missed a bit. What do we do with that now? Are we still doing that? Or
do they sign it? Do they? We were under the impression that weren't countersigned, generally speaking.
Yeah, we do.
Ours are
we
countersigned.
Sign it, and then we send it to the oncology pharmacist to then release to order the chemo in.
Happy for that practice to continue, Mark?
Well,
why do we count?
Yeah, why are you countersigning?
Our site is Toxic Suite won't take your. We have to get them to countersign by our region. They won't take your prescription.
Yeah, our pharmacy won't accept it either without it countersigned.
Needs to be countersigned.
And your manufacturing's Baxter's, or?
Yeah.
So presumably that's a Baxter's universal thing, is it? Radhika?
It might be it might be a hospital-based decision rather than a Baxter's thing. My understanding wouldn't be that it's a Baxter. It'd be an arrangement or an agreement done between the pharmacy and the unit. As Dean mentioned, as part of the new requirements, what we've done is we've put in the requirements as per the Director General. So again, I guess we could leave it to your institutions to do as you please. The intent of the prescription is that you don't have to countersign it, but if you feel or your services make that decision based on your in-house decisions, you're welcome to countersign it. It doesn't negate the prescription that's already been sent.
We don't feel like it's a legal requirement, is what we're saying, and then it's instead an internal governance decision, by your services.
There's a chat that I'll have with the pharmacy here then. Yeah, see how we go. Yeah, cool. Thank you.
Good questions, thank you. Any other questions or concerns? We'll update our slide to cover the date change thing for tomorrow's group.
I had some things I wanted to mention as well, but just let me know when's a good time to mention those, Dan.
I think we've finished. Is there anything else you'd like to cover, Dean?
No, nothing from my end, only if there was any other questions. Otherwise, over to Mark.
So if you do think of other questions for Dean and Radhika, just feel free to interrupt me. But essentially, there were kind of 4 things that we had been wrestling with over the last kind of few months that we've chosen to kind of defer into the go live of this to put the changes in place. And so there will be a few other changes to the way we operate that are rolling out at the same time. Some of them are things you may have had wind of or not, but essentially transfusion irradiation requirements. So the previous policy around irradiation of blood products, we have gone with a safety first approach, which has been in place for like 1 million years, and increasingly has been clear that it's been outdated. Since universal white cell depletion has been in place, there's been much less, if any, risk associated with not using irradiated blood products in the vast majority of our patients. And so it's become increasingly labour intensive, I think, particularly for the regions to deliver this, and sometimes resulted in harm because of delays in transfusion and transfusions ending up in the middle of the night because you've waited for an irradiated product. So after careful kind of review of the policy, we're basically bringing ourselves into line with more international guidelines where there's a much more limited profile of people that require irradiated products. Because some of those are drug related, some of them are disease related, some of them are drug related, some of them are other reasons, but essentially the group is quite small. And so the vast majority of patients that you'll be treating, you will no longer need irradiated products. And we were anticipating that most of them will be notifiable via the RAO system. So that's one of the safety mechanisms, but the blood bank themselves will have notification of who needs irradiated products and who doesn't. So the big change, I guess, for you as regions is we've drummed it into you for 1,000 years that whatever you do, don't give children products that haven't been irradiated because you may cause harm. And so that is now a thing of the past. And yes, there is a very small chance that we may get it wrong and blood bank may not have the right notification, but the vast majority of the patients will no longer be needing irradiated products. We've chosen the go live with this to be the kind of the rolling out of this. So it's a, yes, there is, that information's out there. If you're getting stuck in the middle of the night between now and then, feel free to make sensible decisions. And you may have had some mixed messages around this over the past few weeks from our team at times, but essentially it's a reasonable change that is bringing transfusion irradiation really down to only those who are getting a transplant be it auto or allo, those who've got fludarabine as part of their chemotherapy, those who've had Hodgkin's disease, though the list is relatively short. I can't remember them all. Severe aplastic anemia, I think, is the other one. So most of the kids that you're seeing and transfusing in your regions would no longer be on that list, but blood bank are the people that control those requirements. And so if they are issuing you a non-irradiated product, then feel free to query it, but please do give it as issued. Would be. So it will be a big change, and I appreciate that may be hard to disseminate all the information, and we're always happy to take those calls at this end if there's information or if there's queries about it, but where it will be a big change in practice. Any questions? I'll find the list and disseminate it so that it's clearer than my random remembering of trying to remember who it is. Any questions about that? Okay, great. People are probably jumping up and down with enthusiasm over the change. The next thing is pegylated asparaginase levels. So because it was hard to kind of get that practice embedded, these scripts will allow us to trigger the needing to do levels. So Danielle, so in terms of who would require it at suspected diagnosis, the list would be very short in terms, so because it's going to be allos and autos, they're not going to need it at that time point. Hodgkin's, it's really, probably theoretical, and so prior to chemotherapy, so prior to diagnosis, they're not going to be on that list. It would be fine to give non-irradiated products. Fludarabine, you're not going to have given it, so it's not an issue at that time point. And the severe aplastics, if it's a work in progress, they're not going to be at a level where that's going to be something that's going to be a real risk at the diagnosis at the original time point when you meet them for the first time before they've made it to our service, if that's kind of the question. Okay. Asparaginase levels. So doing levels for asparagine depletion has become kind of universal practice around Australasia. There's been guidelines that have been put out, and we've been very slow at putting those in because we've had this change coming to our chemotherapy scripts. We thought it was sensible to just kind of go live with this because it's easier to put the triggers in so we don't forget that. So there will be some time periods post asparaginase levels that there will be a request to do asparagine depletion levels, which will send out the kind of the information around that. I don't know if some people have already done some. It won't be for all of them. It won't be for the first dose. It won't be for the standard risk favourables, but it will be something that may be required of you at the visit after they've had asparaginase. And we'll set up that. Most of they're actually processed in Christchurch, and so it's not us that the lab is sending them to, but we'll be able to run you through the lab process in terms of getting that stuff done. The other thing about asparaginase is the pre-meds with asparaginase. The Australasian guidelines have different pre-meds to the ones we've been using previously. Oh, here we go. So that is, you need to turn off your blur, Amanda. So perfect. But those will be available once we get it organised via the Starship clinical guidelines and or circulated. But essentially, cetirizine is essentially the drug of choice rather than loratadine or phenergan. And so if you don't have access to that easily, it's fine. We just want them to have an antihistamine, but just the scripts will start to talk about cetirizine because of the Australasian guidelines and because of a liquid preparation availability rather than the tablet. So it just will be easier going forward. So, but no drama if you continue to wish to use loratadine or something else that you have locally available, but just there will be a slight change with that. The last thing is pregnancy testing. So just it probably won't apply at your end, but there will be. So essentially, we've found that we are behind the 8 ball again in the checking for pregnancy in girls, obviously. So our unit policy has tried to catch up with this, and so the idea is we will now be essentially universally testing for pregnancy to exclude pregnancy in girls over the age of 11 prior to the beginning of each cycle. So most of that will be done here. I don't know how often that will actually fall to you in the regions, but that will be something that potentially is new information for families that are on treatment or partway through, or new patients. So if that's new information that's kind of coming up, just wanted you guys to be aware of that. Questions around that?
Just wanted to say around the asparaginase, that ends child document that Amanda was holding up, has different information to what's currently on the NCCN clinical guidelines, and so we are wanting to amalgamate the information so there's sort of a single, non-ambiguous bit of information, but we just haven't got there yet. A work in progress.
Cool. And I guess on that theme, some of our guidelines are a little bit out of date, and if there are changes in practice that you guys pick up because you were looking at the guidelines, because to be honest, a lot of the time we don't look at them in the same way. But if you're looking at things and notice that our practice no longer aligns with what our guidelines says, please feel free to flag it to Stephen.
Yeah, agreed. Yes.
or me.
When Mark says some of them are out of date, that's true. Many of them are really out of date. There aren't too many that are current, so that's the problem. But we're working on it.
Thank you. Were there other questions for Dean and the chemotherapy prescribing team that have come up?
Dean, were you suggesting if regions were interested in logging into that might be a possibility, or?
I think that would be we'd say that's our medium term kind of goal, but we'd have to do it on a region by region basis. But yeah, certainly logging into the system is preferable to all this paper handling, because it's quite straightforward to log in externally. It's just the change side of it that's difficult.
Yeah, I mean, it seems madness to have something that you could be logging into and use as a standalone system, but we haven't got there yet. But I'm confident that we will get there in the medium term.
Great. Well, thank you everyone for joining us. I appreciate your time. And yeah, in 14th of October, I guess we'll start to see those. And any feedback once it starts, please do get in touch if there's any feedback. Have a good afternoon. See ya.
Right. Thank you.
Thanks, everyone. See ya.